yesterday we talked about first-line therapy, had a great discussion and a lot of data. Now we're moving beyond first-line therapy, and it's a little bit more of an open field. There is data, though, and we're going to go over that. And we have 4 speakers. And Dr. Pashapayan, we're going to start with you and jump right in with Beyond First-Line Therapy, selecting further lines of therapy after IO-TKI. So we'll be going through the different first-line therapies and into how we manage subsequent.
Okay. Good morning, everyone. And it's a pleasure to be here. Thank you to all the organizers and all the panel chairs for inviting me to give this talk on Beyond First-Line Therapy, selecting further lines of therapy after IO-based regimens. And I'm going to start by saying these are my learning objectives, which is factors promoting decision-making in second-line therapy, the different treatment options, and monitoring clinical outcomes. And I will show you across my talk that this state of disease currently is extremely understudied. So we have a lot of work to do. There are no real contemporary trials or data. It's just beginning to come out. So at this time, when you're treating a patient, facing a patient, post-frontline IO therapy, you're really dealing with very little prospective evidence. So these are all the studies in pretreated metastatic RCC, and the Cabo versus everolimus METEOR trial, Checkmate 025, which led to the first immune checkpoint inhibitor being FDA approved in kidney cancer, axitinib versus sorafenib, so the TKI backbone, which is pretty much remains today the mainstay of therapy in the second-line setting. And then tivozanib versus sorafenib, one of our more recent FDA approvals. And then, of course, lenvatinib and everolimus combination. So these are sort of the previous phase of post-trials, post-VEGF TKI, and here are the ones with everolimus getting established as standard of care. So, after VEGF TKI, mTOR inhibition. I would argue that most of our studies currently are dealing with initial VEGF TKI-based therapy and then following it up with some kind of regimen. So all of our FDA approvals right now, the Nivo versus everolimus study, of course, post-VEGF TKI therapy, so doesn't really apply to our contemporary frontline therapeutic regimens. And this showed overall survival benefit, no PFS benefit, METEOR trial, post, again, predominantly VEGF TKI. There were only about 15 patients who had received prior IO therapy in this study. So again, this study led to the FDA approval of cabozantinib, showing PFS and OS advantage. This is a small study of lenvatinib and everolimus, but it showed a large magnitude of efficacy advantage, as we know, with a median PFS of 15 months in this small select patient population, favoring the combination of lenvatinib and everolimus, leading to the FDA approval, at least in the US, of this agent, of this combination. The ACCESS trial. So this study sort of brought to the forefront, besides bringing axitinib to the forefront as a therapeutic regimen, it showed us that prior therapy matters. And by that I mean that prior cytokine therapy showed a median PFS of 12 months, as compared to prior sunitinib therapy, median PFS was 4.8 months. So that tells you that the frontline regimen is really going to have a huge impact on when you're presenting to your patients your second and third line options, which currently you don't have prospective evidence for. So just keep that in mind when you're thinking about what you're presenting to the patients in the second and third line setting. Omnivore trials. So there was a series of studies, 2 or 3 studies, as we know, looking at post-nivolumab, trying to do ipilimumab. So trying to change the type of immune checkpoint inhibition from PD-1 only to going to addition of CTLA-4 inhibition. And clearly, each of these studies have consistently shown us that doing ipilimumab, or CTLA-4 inhibition, at least currently the way we know it, is not all that effective. Modest response rates. There were some long-term remission rates, but again, those could have been just from single-agent nivo also. So the Omnivore trial is one example, and then there was the HCRN study, pretty much showing you the same thing, single-digit response rates, not worthwhile to add ipilimumab, at least after nivolumab-based or for initial PD-L1-based regimen. Moving on to the TiVo-3 study design. So this one maybe had slightly more immune checkpoint therapy pre-treated patients, but again, not as many as you would think. So this study randomized patients to get up to 2 prior regimens, and majority of the patients had received 2 prior VEGF-TKI therapies. And the interesting thing is that the VEGF-TKI backbone does continue to be effective over and over in about half of the second-line and beyond kidney cancer patients that you treat. So this study randomized patients to get tivozanib versus sorafenib. Treatment continued until progression. And these are the results showing a progression-free survival benefit. However, no overall survival benefit as of now. What this study is showing, though, that there is a small proportion of patients that have a really long duration of response. So there is this very VEGF-sensitive patient population that you can identify and actually continue to treat in this setting with agents such as tivozanib. There is some retrospective data of TKI therapy post immune checkpoint inhibition. This is one example. There are a few others of this kind of retrospective multi-center studies, again showing overall that the response rates are fairly sustained in the 30 to 40% range with cabozantinib in this instance, and there is some progression-free survival that is achieved with, again, retrospective data. Remember that caveat. So what do we do for relapsed or refractory stage 4 RCC? I think main points to consider is, do you need to switch, and what kind of progression do you have? And the third point I would say is what kind of treatment they got before the frontline therapy is going to impact your second-line, third-line therapies. So these are your treatment options. I mean, NCCN lists them all up there. So, there is a host of treatment options that you have, although how are you going to determine which one? This is probably the HIF-2 alpha as a novel target is probably the next generation of agents. It's leading the way for a phase 3 trial that is being conducted, comparing this agent to everolimus for a FDA registration study. So again, we'll have to wait for the results of that. This agent, as you know, belzutifan, is already approved in the VHL hereditary kidney cancer patients. Okay, so in the HIF-2 alpha inhibitor belzutifan, this is the data for objective response rates in patients with VHL syndrome. So almost 50% of the patients had kidney cancer responses, but besides that, HIF-2 alpha inhibition also produced responses in CNS hemangioblastomas and pancreatic neuroendocrine tumors. So very interesting data, and this paves the way potentially for sporadic kidney cancer results with belzutifan. Recently published belzutifan and cabozantinib combination in kidney cancer. This just came out in Lancet Oncology. 52 immune therapy pre-treated patients. Some prospective data, small numbers. Objective response rate, 31% of the patients. Majority had some tumor shrinkage. 87% had some kind of clinical benefit. Median response duration. So the patients who did respond had tended to have durable remissions. So very exciting combination data that is coming up. Again, needs to be validated in a prospective phase 3 trial, but shows some promise. Overall survival. Median survival has definitely changed and improved, especially with the frontline therapy improving. We don't know yet if we have made a big splash or a major impact post-initial immune checkpoint combination in the second-line and third-line therapy, and I think we have to wait it out for those prospective trials. Then there was recent disappointing data that continuing immune checkpoint inhibition, similar to the CTLA-4 inhibition that I showed you, consistent phase 2 trials showing very modest clinical benefit after initial PD-1 inhibition, phase 3 CONTACT-3 study that showed no benefit as of now. It did not meet its primary endpoint of progression-free survival. The actual data is not yet known, and I'm sure will be presented soon at a meeting. But this was a study that randomized patients post-immune checkpoint therapy in the second-line setting to cabozantinib single agent plus minus atezolizumab, another PD-L1 inhibitor. Okay, the type of progression. So think about things as oligoprogression versus diffuse progression. And I think you will find that about a third of your patients will have this kind of oligoprogression. I mean, I've had patients who, even to give you extreme examples, have had liver mets that 1 or 2 of them have continued to progress. Everything else has been in remission, which typically then you can address with different local therapies. So, and keep going with your frontline therapy. So that is definitely a strategy we all should employ and consider. Again, not quite proven in prospective settings, but that would be very much a patient selection thing. But that is something, and there is a SOAR trial that will be looking at the role, again, in the frontline setting, not second line, from the NCTN that will be looking at this early oligoprogression or oligometastatic disease and trying to address it with SBRT and delaying systemic therapy. Clearly, for the diffusely progressing patients, it's pretty obvious. They're clinically symptomatic. You can tell on the scans. And prior therapy, depth and duration of response to previous treatment will obviously play a role in your future treatment decisions. But what we do know so far from the current state of evidence is that continuing the IO regimen does not seem to make sense as of now. Different common treatments, I mean, obviously you can do thermal ablation, surgery, and then drug therapy. Of course, we discussed quite a bit in detail. But active surveillance is not completely unreasonable to consider, given, like, for instance, I have a patient right now who has a number of cardiac issues, and the disease is maybe progressing slightly, so I figure, I will take her off all treatment for cancer and let her deal with the cardiac issue while we continue to monitor. So that is definitely a very reasonable thing to consider. There are multiple other pathways that have been reported. I've listed a few of them. The biggest thing I think that has been brought up in this meeting, and Sarah just mentioned, is assessing the patient and the overall expectation of where this patient is going. And quality of life or patient perspective is a big, big fifth vital sign that we have, and it's underrepresented in almost all of the clinical trials. So that is something you have to keep in mind when you're considering the patient goals and outcomes of therapy. When to switch therapy. So this is one of my pet peeves, and we all fall into this trap now with patient portals. The patients are continuously harassing you with these kind of wordings in the radiology report. And here I have an example of a small 3-millimeter non-calcified solid lung nodule in the left lower lobe, and this they call has increased in size. Now these are exact words from the radiology report. Progression of disease due to new lung metastases. Please, yes. Please, consider the progression. I will just bring up a couple of more points that, there are a number of other prognostic characteristics that we need to be considering when we talk about, the Heng prognostic score clearly is there, but for second line, third line therapy, does the equation change completely based on their previous treatment? This is a paper that we reported that the duration of VEGF therapy seemed to imply and predict for responses in the post-VEGF therapy. At the time, we were using IO therapy, and we looked at IO-treated, pre-treated patients, but looking at whether it was predictive of IO responses. So this is PFS and OS from that. So I would argue that second-line therapy, the second-line patient is an extremely heterogeneous patient population. I would suggest considering all of these different subcharacteristics in the patient populations: immune refractory, immune resistant, and immune responsive. And of course, in conclusion, pre-treated RCC, I would again argue, is an understudied disease at this point, because our frontline therapy has changed so dramatically that we haven't quite caught up in the second and third line setting to gathering the prospective data in relation to that. And these are some of the points I raise related to that. So my take-home message is, what does this mean for your practice? Review scans carefully. Please, don't get misled by the wording in the CAT scan reports. There could be a discrepancy between the clinical picture and imaging, and that should be interpreted with caution. And then quality of life, toxicity management, and patient perspective should play a huge role in your treatment decisions in the second line. Thank you.
Thank you, Dr. Veshenpayan. Now it's my pleasure to introduce a friend, an expert in the field, Dr. Ignacio Duran from Spain, currently at the University Marqués de Valdecilla. I hope that's okay, Ignacio. And you will be presenting to us what is the beyond first line for patients who were exposed with IO-TKI first line regimen. Thank you, Ignacio.
Thank you, Lauren. Thank you, KCA, for the nice invitation. Thank you, Scientific Committee, for asking me to do this. I'm going to talk of treatment. You want to put the timer? Yeah. A little bit more pressure. Okay, I'm going to talk about treatment beyond first-line therapy. And the previous speaker, Dr. Veshenpayan, spoke about what to do when our patients progress to IO-IO. The task that I have, what I have to talk about, is what to do when our patient progressed beyond IO-TKI. So when I was preparing the talk, I thought, okay, what should I have as learning objectives? And I thought, well, first get the audience familiarized with the current situation in MRCC therapeutics. I think at this point that is pretty clear, so we'll go very quickly through that. But then the second objective, which is particularly the one I have, is review the evidence regarding treatment selection beyond progression to IO-TKI combo in first-line MRCC. These kind of talks, and mostly when you're the second presenter, always there is a risk of overlapping, so you're going to see a little bit of overlapping, but repetition is also a teaching technique, so it's probably going to be helpful to kind of send the message more deeply, but we'll try to get that right. So this is the outline I'm going to follow. Don't worry, moderators, I'm going to finish in the 10 minutes. I'll go very quickly through this historical perspective, the context, and then we're going to go through the different options in this context. So this is the historical perspective, and there are a few young people in the audience, so they should know that kidney cancer in the metastatic setting has not been so brilliant for a long time, and we went through different times, and back in the 1980s, the situation was quite different. But the important thing is that if you look at this slide, at the bottom of the slide, there are the major biological findings that support what we've been doing. And we started to learn back in the 1980s that this tumor was an immunogenic tumor. And there are reports from those years of how immunotherapy was effective in kidney cancer. And what I want to show is how we've been learning progressively about the tumor. Biology is important. It's not only about combining A plus B plus C, it's about knowing what is underneath the tumor. And this is how we've been building this whole schema until 2022, where we're dealing with the triplets, which is kind of conflicting still, and we have the HIF inhibitors. So having that in mind, this is our context. So we've done a long way. We've made huge progress in kidney cancer, and right now in first line, and we've been discussing this yesterday, we have the checkpoint inhibitor combinations, either IO-IO or IO-TKI. And this is fantastic, and our patients live longer, and we have some patients that we call cured. But despite these remarkable results, there is still a percentage of patients that are going to require further therapy. And the challenge is, how do we treat these patients upon progression to IO-IO or IO TKI. And the first thing I could finish here my presentation is there is no consensus on the optimal second-line therapy. I'm not going to be today the level 1A evidence guy, I tell you that. So I'm going to try to share with you what is out there and how we can build up that decision when we're in the clinic. So first block, a patient pretreated with an IO TKI combo. Would it make sense to give this guy a VEGFR tyrosine kinase inhibitor? Well, the answer is, so far we have this kind of situation. We have a mix of studies with very variable populations, including different previous treatments in first line and further, a small sample size, many of them, most of them, I would say, retrospective, and some of them subgroup analysis. They could be summarized in a couple of tables. I don't want you to see the whole detail in this table, but I just want to bring your attention to a couple of things. Look at the number of patients in these analyses. We're talking about somewhere between 5 to 86, the most of them. So small studies, most of them retrospective, and some subgroup analysis. We could summarize this table saying the overall response rate in this context of a VEGFR tyrosine kinase inhibitor after checkpoint inhibitor IO is about 30%, and we could say median PFS is around 6 to 8 months. These are all serious, some of them, and this is a newer table, but the data is, again, relatively similar. Here we see a couple of prospective studies, phase 2 studies. Again, the number of studies is small. We're looking at a small series of patients, and again, the response rate is kind of in the 30s. Okay, let me stop very quickly in a couple of them. TiVo-3 has been commented before. It's a third-line plus study, randomizing patients to TiVo and sorafenib. And the important thing in this study that has to do with my presentation is that about 25% of the patients had received IO TKI. And the message should be that those patients achieved a progression-free survival of 7.3 months. We do not have the overall response rate specific to those patients in the TiVo-3 study. So it's just a little hint on what TiVo in that context could add to this patient population. There is another small phase 2 study published not so long ago by Giuseppe Procopio, and this study shows something similar, is the activity of cabozantinib. And what we're seeing here is about a fourth of patients were post-ion TKI, so it's a good opportunity to see how a VEGFR tyrosine kinase inhibitor would work in that population. And again, you see similar numbers. We go to the 30s in the overall response rate, 37%, median progression-free survival, 8.3, median overall survival, slightly over a year. Some data from Cantata. We have Dr. Tanir here, and some of the patients, and this is actually one of the studies where we said, okay, we can actually say that VEGFR tyrosine kinase inhibitor work after immunotherapy because we knew there was a percentage of patients that had received prior immunotherapy. I don't know how many were IO TKI. I don't have that data exactly, but it's another hint of activity of these drugs. All those things were retrospective or sub-analysis or a small sample size. Then we're waiting for something prospective. And then Laurent came to give us that solution, or we thought that was going to be the case. And this is a prospective evaluation, the Cabo Point study. 2 cohorts, patients treated with IO-IO or patients treated with IO-TKI would receive cabozantinib. This study evolved over time in its design. The sample size unfortunately decreased due to several reasons, but basically, we heard recently in ASCO GU presented by Laurent the data, and this is the cohort that I am interested in, and it's the cohort of patients that received checkpoint inhibitor plus VEGFR TKI. And you can see here, cabozantinib overall response rate is about 25%. The downside of this is the small numbers. Again, this cohort is only 28 patients. Okay, so with this, I could say that, VEGFR tyrosine kinase inhibitors, the evidence regarding the activity of these compounds following IO-TKI in MRCC is scarce, mostly retrospective, mostly small sample size. Recently, we have heard prospective data, and I think with all these, we could, take into account all these limitations, we could say that, an alternative VEGFR TKI is probably a reasonable option beyond progression to IO-TKI in our daily practice. But there are other situations and other data. What about treating my patient who progressed to IO-TKI with more IO? Does it make sense? The answer is probably no, and this is just a few very short messages from studies where there is mixed populations. Not all these patients were IO-TKI pretreated, but it's to show that sequencing IO before and following IO to rescue, probably we're talking about response rates in the range of 15 to 20%, and it scores the long-term benefits, and that's been shown in different studies, and we discussed these, and was beautifully presented yesterday by Dr. Atkins, the propensity score analysis. So I would say that's not probably the ideal way to go. What about if I have a patient pretreated with IO-TKI? What if I give this patient IO-TKI? Well, it looked exciting, and this study has been commented before too, the lenva-pembro. Out of 104 patients that received lenva-pembro in this study, there was 18 patients that had been previously treated with IO-TKI, and in this group, the overall response was 39% almost. So it was exciting, and people thought, okay, maybe this is the way to go, and that was probably behind the rationale of CONTACT-03. But as recently mentioned, this study has not succeeded, and all we know is this press release that the study is negative in its primary endpoint. So we will have to wait to other studies like TiNivo-2, which is testing a similar approach, giving IO-TKI after having received that before. Okay, so IO-based strategies beyond IO-TKI. I think exclusively IO-based strategies beyond progression to IO-TKI do not seem to provide enough activity to justify use in this clinical context as an alternative. There is interesting data around, the lenva-pembro study. Nevertheless, CONTACT-03 negative. We'll have to wait these ongoing studies. Before I finish, this is the one before my last slide. I just want to tell you that, as has been commented by my previous speaker, treatment selection is more than just what the patient received. We need to integrate all these factors, patient factors, disease factors, and of course, treatment factors. So last slide, final remarks. Selecting treatment beyond progression to IO-based therapy in RCC is a complex process. It's not simple, and many factors need to be taken into account. The current evidence around treatment beyond TKI is scarce. There is not so much out there, and we need to interpret these results cautiously. An alternative VEGFR TKI seems to be the option, and this is what is recommended in most of the guidelines. It's the greatest level of evidence that we have, and probably the more balanced benefit-toxicity ratio. But of course, we've got ongoing prospective randomized studies that may help us define this clinical scenario, and we're waiting for those results. Thank you very much.
Thank you very much, Dr. Durand, for your excellent presentation. And now it's my pleasure to welcome to the podium our co-chair of the meeting, Dr. Gabriel Malouf, Professor Gabriel Malouf. Gabriel and myself trained together. He's a close friend, and he will be presenting on integrating predictive biomarker into therapy selection. Gabriel.
Yeah, thank you so much, Laurence, for introduction. Thank you so much for the co-chair. I think my previous colleagues, Ulka and Ignacio, introduced very well, the topic, introduced very well the difficulties to try to identify the optimal treatment for the patients. And the task that I have been given for the 10 minutes is try to see if we can have biomarkers that can help us select the patient and select the good treatment options for the patients. So the learning objectives is first to gain knowledge on the role of the genetic and epigenetic alterations of the tumor to see if these can help us, first point. Second point is to try to see if the microenvironment, so the role of endothelial cells and the immune cells, can help us to select the optimal treatment option. My talk will be divided in two parts. The first part, I will summarize what are the evidence currently available to select the optimal treatment for patients. And the second, I will provide some personal data from our lab on some biomarkers to allow better stratify the patients. So if we look currently at the ESMO guidelines, so you can see very well that the only biomarker that is available is IMDC criteria. IMDC criteria is the only biomarker that we have that can allow us to select patient for IO-IO or for IO-TKI. But if we have other data, we do not have so far. Before going to the talk, I would like to remind you that the cancer ecosystem is the cancer cells plus the immune cells, plus the stromal cells that are the endothelial cells and the fibroblast. So what are the biomarkers? I think, each person is looking, in the field where he's working on. Some people are looking at clinical biomarkers, so IMDC criteria, the sarcomatoid differentiation. Some people are looking at the cancer cell, so the role of genetic and epigenetic alterations of the tumor. Some people at the microbiome. We have a lot of investigators. We have listened about yesterday, investigating the role of circulating biomarkers and, of course, the role of tumor microenvironment. So if we go at clinical criteria, I think it has alluded to, we have the role of sarcomatoid differentiation, where we can see that it might help select the optimal treatment. And we can see that in different cohorts published today, the response rate of patients with sarcomatoid differentiation is high as compared to sunitinib, and we can see it for the CheckMate 214 cohort, 61% versus 23%, for instance, for sunitinib, and it's the same thing for the other trials with IO-TKI. If we look at the genetic alterations of the tumor, we know now that the TMB is not a good biomarker as compared to other tumors, as, for instance, colon cancer or other types of tumor. If we look at the data of single gene mutation, the data is really contradictory, with some data suggesting the beginnings that PBRM1 might be associated with good response to IO, but we have other papers from MD Anderson showing the opposite, with PBRM1 associated with immune desert microenvironment and is resistance to immunotherapy. If we look at the gene expression signature that has been established so far, what is interesting is those gene expression signature has been done based on the tumor, but the signature that is associated with the response is related to expression of immune and vascular genes. And the first papers has been published in 2018 by David McDermott, where they have the iMotion 150 signature, where they have a signature that is based on vessel and based on immune genes, and they divided the population in signature which is angio high or T effector high. The angio high is associated with response to sunitinib, and the T effector high is associated with better response to IO. And then we have the Javelin cohort, where we can see that the expression of 26 immune genes, again, is associated with response to IO. However, if we look at the subsequent cohort, and this is the case, for instance, for the CheckMate 214 cohort, so those gene expression signature, we could not validate them. So what we have is just the angio signature, which is associated with response to sunitinib, but we do not have any association with response to IO-IO. Another topic that is interesting is the expression of some ERV, so endogenous retroviruses, that represent 6 to 7% of the genome, and there has been some key publication by Kim Rathmel lab showing that the expression of some of these ERV are associated with response, and also a nice publication from Samara Turajlik with the adapter trial in cancer cell showing that maybe we have a subset of ERV that are associated with response to immunotherapy. So what we can do next? So our lab has tried to investigate if other biomarkers can be associated with response to immunotherapy other than gene expression signature and other than the mutation. And we investigated the role of DNA methylation. DNA methylation is a stable modification of the DNA. And we looked whether subtype classification of the patients in bionic trial according to DNA methylation can divide the patients according to responders and non-responders. So what we have found is that hypermethylation or hypomethylations are not associated with response to immunotherapy, but we discover a subgroup of tumor that we call TED, is tumor with enhancer demethylation. So this subtype of tumor that you can see in the slide at the extreme left have a huge hypomethylation. So this is the blue that you see at the end of the tumor as compared to the other group of tumor that have a lot of yellow that are hypermethylated. So for reasons that are unknown, we have a subset of tumor that demethylate their enhancers. And this subset of tumor is associated with activation of TGF-beta, is associated also with activation of interleukin-6, and it's associated with resistance to immunotherapy in bionic cohort. What is interesting in this group of tumor that is called TED, that this group of tumor is associated with sarcomatoid differentiation, and it's highly infiltrated with fibroblast and with immune cells. So it has both. It has cells that are activating the immune system, and it has cells that are suppressing the immune system. Another work that has been done in the last 3 years, but by many investigators, including Ari Hakimi in Memorial Sloan Kettering, is using single-cell sequencing techniques to try to see if it helps us at the single-cell level to predict patient response to IO. And this is one of the first paper published in single-cell sequencing of renal cell carcinoma. It's only 6 cases, but it has been a landmark paper where you can see that the RCC are heavily infiltrated with lymphocytes. So we have a lot of CD8, but we have a lot also of macrophage. And what Ari and his team has found, so of course, here you can see 6 patients only. So you have some patients that responded and some patients that do not responded. And what we can see that the patients that respond have expansion of CD8 cells, and we have less macrophage. And the patients that are resistant to IO, they have more macrophage and they have less CD8, suggesting that we might use single-cell sequencing to help us in deciding, if the patient is going to respond to IO or not. In our group, we try to analyze the crosstalk between cancer cells and the immune microenvironment. And we have done this study on 10 ccRCC, where we have performed single-cell sequencing. And you can see in the UMAP that the majority of the cells that we get when we analyze these tumors is the lymphoid cells, but we have also a lot of endothelial cells because, as you know, ccRCC is angiogenic disease. And when we looked at the plasticity of cancer cells and we analyzed specifically the ccRCC cells, we saw that the cells can be divided in 5 categories. Some of the cells have really epithelial program. The extreme is mesenchymal program. We have a group of cells that is really inflamed. So it's overexpressed MHC class 2 and other genes associated with inflammation. And we find that the majority of the cells are in the middle is intermediate phenotype. So what are these implications? The implications is we try to see if any of those different 5 subtypes of cancer cells are associated with any cells of the microenvironment. And as you can see here, and this is data from bionic cohort, so we did the deconvolution of the RNA sequencing data, and we saw that the mesenchymal cells, so the signature of mesenchymal RCC, often associate with cancer-associated fibroblasts. So we have an association between mesenchymal cells and MyCAF, and we have done some spatial transcriptomic and IHC to show proximity between cancer-associated fibroblast and mesenchymal cells. And what we show that the patients that have high level of MyCAF in bionic cohort are associated with resistance to IO in terms of progression-free survival and overall survival. So this is suggesting that we have a crosstalk, so the MyCAF is talking to the mesenchymal cells, and this is leading to metastasis and aggressiveness and resistance to IO in this setting. So in conclusion, there is currently no approved biomarkers to stratify treatments of patients with advanced ccRCC. There's many clinical parameters that can be useful, as the IMDC and sarcomatoid differentiation. The TMB and genetic, so far, the results are really inconsistent. Epigenetic might really provide an added value in predicting response to IO. I think we should do more work on epigenetic, and new techniques such as single-cell RNA sequencing, spatial transcriptomics, is really coming and is shedding a light on the crosstalk between cancer cells, the immune cells, and the microenvironment. And I think these can be really helpful in the future to allow us better predict the response of patient and design new treatment. Thank you.
Fantastic, Dr. Maloof. We appreciate that. And now to wrap us up on summarizing and optimizing later lines of therapy selection is Dr. Camilo Porta from the University of Bari Amara. Welcome.
Thank you very much. First of all, I want to thank KCA for inviting me, although the title of this presentation is quite challenging because how to optimize later line therapy selection is still an unsolved issue in the field of kidney cancer. So this is why we do not have high-level evidence supporting our later line treatment decisions, because ultimately randomized clinical trials are lacking. And furthermore, across the globe, we have also to deal with regulatory restrictions. Therefore, in order to optimize treatment, with the aim of prolonging as much as possible our frontline therapies, is a primary goal in our clinical practice. And this goal can indeed be achieved by means of adequate therapy management, careful identification of progressing patients, integration of local treatments within the backbone of systemic therapies, especially in the case of oligoprogressive disease, and finally, identification of possible novel therapeutic targets, if any, on an individual basis. But first of all, we have to answer a key question here. How frequent is in clinical practice the need for a third or further treatment line in metastatic kidney cancer? Because as clearly stated in this well-known editorial by Tom, we can speak about a low diminishing returns, meaning that moving from one line of treatment to the other, we are losing patients. So how many patients really need such advanced treatment lines? These are the data from our institution. As you can see, as much as 28% of our patients do reach the third line setting, and 16% receive a fourth line treatment. But again, we have a lot of limitations. We do not have high-level evidence to support our decisions because clinical trials are lacking. We have regulatory restrictions limiting the possibility of using many agents, at least in many countries, including Italy. Despite the fact that we theoretically have a number of active agents. Don't be surprised to see in this slide all treatments such as interferon, interleukin-2, or temsirolimus, because please keep in mind that all these are active agents, even though many of them are presently seldom used because they lost head-to-head comparison with most recent and more active agents. But still, there are many active agents out there to be used. So what? First, we should try to keep patients on treatment as much as possible. This means that we should try to avoid to permanently discontinue treatment due to toxicity, unless one have tried to prevent, whenever feasible, the more frequent treatment-related adverse events. Just an example, enforced skin reaction from multi-kinase inhibitors. And until you have proactively and aggressively managed them, taking into account that nowadays we have a number of very well-written guidelines and real-world suggestions we can use in everyday clinical practice. Whenever possible and whenever needed, confidently use drug holidays and dose reductions, the former probably being better, for the management of adverse events related to tyrosine kinase inhibitors and mTOR inhibitors treatment-related adverse events. as well as steroids for the management of immune-related adverse events, although in this case, the main issues are the identification of the right time, the right dose, and the right period of steroid administration. This is therapy management, and this is key. But what else can we do? First of all, always take your time. In medicine, rush is almost always a bad advisor. Let's take a look at this patient of mine. This patient was progressing on a first-line treatment and then started a second line, no matter what it is. And after some months of treatment, he developed this lung picture, and the radiologist suggested the possibility of a cancer lymphangitis. Is this a progression needing a change of line? No, it was COVID. And we kept the treatment, and the patient is still on treatment. Something more. This is another patient with bone, hepatic, and lung metastasis. And we can see in this slide 2 target lesions, one in the lung and the other one in the liver. Pembroxy combination first line was started, and after almost a year, he developed a progression in one metastasis only, in the lung, but it was a 51% increase. Is this the case for changing therapy? Again, no. We performed as BRT on the progressing lung metastasis. And after treatment, the lung metastasis reduced in size, and the rest of the disease remained stable, while the combination was still ongoing. And finally, this is something that we should use very cautiously, but still, there is a potentially very important tool to use in these patients. Another patient of mine, MRCC, progressing after a first-line ipi-nivo combination and after a second-line cabozantinib monotherapy. And under cabozantinib, the progression of this patient was massive. We considered all the available options in our country, and at the end of the day, we offered him to receive everolimus. But he said, I don't want to receive this drug because it is old, it is not so active. So we decided to perform a Foundation 1 liquid biopsy, which indeed evidenced the following genomic signature: EGFR, MAPP, mTOR, VHL, CDKN2A and B, microsatellite stable, tumor mutational burden low. So what to do? We went into the molecular tumor board and discussed this profile. And our geneticians said, there is nothing you can use. But still, there was an mTOR and VHL mutation. And at the end of the day, we decided to try the lenvatinib everolimus combination in these patients, which was an off-label use in Italy. Does all the above make sense? Probably not, but ultimately it worked, because after 9 months of treatment, the patient was stable and continuing lenvatinib and everolimus. And few final considerations to keep in mind, which in my opinion are very important, especially for younger people. It is clear that the number of long-term survivors is increasing in kidney cancer. And with it, it comes the need, the issue of a growing request for later treatment lines. Again, in the absence of high-quality randomized control data. However, and this is quite important in my opinion, do not treat a patient just because it is difficult to say no to the patient or his or her relatives. And remember that best supportive care is always an option which should be considered, especially in highly pretreated patients and especially when performance status is declining. Thank you very much for your kind attention.
Thank you so much, Camilo, for the great presentation and catching up the time. So we're going to open the floor for a couple of questions so that we remain on time. Please move to the microphone. While you're coming, maybe a question to Ignacio. So Ignacio, in practice, you've shown us that you may use another TKI that you haven't used in first line. How do you choose?
Mm-hmm. Well, thank you, Lauren, for the question. Basically, what we should take into account is what we used before and try to switch. So if you have used, axitinib, pembrolizumab, probably the TKI that has the most data would be cabozantinib in that context, and I think that would be my choice. On the other hand, if you've used cabo-nivo as your first line, then you have to switch to a different tyrosine kinase inhibitor. One could argue there is not a lot of evidence about any concrete TKI. Probably, axitinib would be a reasonable option based on what we have. But you could also use tivozanib if you have. So any tyrosine kinase inhibitor that has not been used before would be a reasonable option to me. And if you haven't used cabozantinib, it's probably the one with the highest evidence.
Thank you. Dr. Gilles?
Hi, this is Rachel Giles from the International Kidney Cancer Coalition. So, Professor Malouf, I have a question for you about your talk. There was a fascinating group of fibroblast cells that you pointed at, and I was curious if some of the single-cell transcriptomics picked up whether those were due to perhaps a localized or focal regeneration attempt that might have been there, or was that actually due to mesenchymal transformation of epithelium that you think that you should have been picked up on that transcriptomics? Where do you think that those cells come from?
Yeah, it's a great question. So if I understood well, your question is where the cancer-associated fibroblast is coming from?
Yes.
Are they coming from transformation of like fibroblast or from somewhere else, right?
Yes, exactly. Are they endogenous or are they recruited?
Yeah. So first of all, I would like to express my gratitude to Stéphane Houdard and Yann Vanneau for the opportunity they provided me to work on Bionic trial. And I mean, in this work, in the single-cell sequencing that we have done, basically, I mean, it's the first effort on the topic. What we found is that you have two types of cancer-associated fibroblasts. So you have what we call the MyCAF, so the myofibroblastic CAF, and you have the inflammatory CAF. And those CAF cluster very closely to the pericyte. So as you know, if you take a vessel, you have the pericyte, and then you have the endothelial cells over there. So what we found a proximity in the gene expression signature between the pericyte and those CAF. But it's a big question in the field whether those CAF are coming really from outside, bone marrow, or it's really coming from the vessels of the pericyte. So far this question has been unresolved. But I think regarding the proximity of the program of pericyte with the MyCAF, I think probably they are coming from the vessel and they are migrating toward some areas of the tumor, and they are cross-talking with the mesenchymal cells to create this immunosuppressive system. So I hope that I answered your question.
Absolutely. It's interesting. Thank you.
Thank you.
We have another question. Samra?
I'll be brief, and thank you for a wonderful session. It's building on the previous question for Gabriel. So you identify these tumor mesenchymal cells through the single cell data, which might be the cells that are undergoing EMT, they could be metastasizing cells. And given that we know something about genetic properties of metastases, would you be able to get at the genetic profile from the single cell data through, inferring copy number changes? Is it something you've done? Do you think it's plausible?
It's a great question. So, I think it's one of the first efforts to try to characterize the plasticity of these cancer cells. And as you know, Samra, when we take these tumor and we dissociate them, we get very few, epithelial cells because we lose them through the process of dissociation currently with the new techniques that are available. So in our effort, we succeeded just to get 2,000 cells, and the mesenchymal cells were coming from different parts of the tumor. So with the current number of cells that we are having, we didn't succeed basically in trying to dissect what's going on. However, we worked basically on the transcriptional level, and we looked at the regulons that are associated with these mesenchymal cells. And what we observed basically is that you have a huge proximity in terms of transcriptomic profile between the proximal cells of the nephron and epithelial cells. And as soon as the cells basically are going toward more the differentiated state, they lose the proximity, they lose linear specific, if you want, transcription factors, and they are gaining the mesenchymal phenotype. But I don't know if this process is driven really genetically or epigenetically. So I think this is one of the questions that really need to be addressed in the future. So I do not have an answer now.
Thanks very much.
Thank you.